Good evening, everyone. This evening, we're joined by Dr. Harry Karpouzis from Pelargos IVF in Greece. As we've spoken before on a number of different topics, but this evening we're tackling the vital topic of when to change IVF protocols after a failed cycle. Something that I know so many of you can relate to, and the level of frustration, especially when you've done so much to prepare. I mean, the amount that goes into a cycle, from the financial investment to the physical impact and the emotional side, it's really key that you're able to take a step back to review everything, because we all know that saying, the definition of insanity is doing the same thing over and over again and expecting a different result. So I know that Dr. Harry will be able to shed some light on this topic for you, and there were tons of questions sent in. Thank you so much. We will be getting to those in detail later on. But before we get into that, just to give some context to the conversation, I figured it'd be a good place to start by actually defining what you would categorize, Dr. Harry, as a failed cycle. Are we talking about everything all in one, like not getting a great amount of eggs, not having them fertilize as well as you'd hope, not having enough embryos? How would you generally categorize an unsuccessful cycle?
A failed transfer is a cycle. A failed transfer, failed cycle is a cycle that doesn't lead to a pregnancy. That's the main aim behind IVF. So even if the fertilization is not that good, if you finally have a positive pregnancy test, the cycle is considered to be successful. So the aim of IVF is to get pregnant. When you don't get pregnant, you need to go back to what you have done. You need to break it down, and you need to try to find explanation so that you can change things.
And in the context of, because obviously there would be fresh transfers or frozen transfers. So I agree, of course, getting pregnant is the aim, but if we're backing up from that, it would probably be getting enough embryos to work with to transfer, especially if somebody's trying to bank embryos, which I know a lot of people are trying to do. So ultimately, yes, you want to get enough eggs, enough embryos, and then have a healthy pregnancy, which is key. So let's say if we're looking at, someone goes ahead with a cycle and everything seemingly looks good from their AMH and their follicle count, that it looks like they should get a decent number of eggs. What would you be advising someone? Would you be looking to the medication protocol and how they responded if it didn't work? So let's say you thought they'd get 6 to 10 eggs, but maybe they only got 3. What's the first area that you discuss or review for a case like that?
Lost you for a while because it was not working, so I couldn't hear you. So
no problem. I could see you was glitching. I'll repeat the question. I was just saying to give people examples of situations that they might fall into that category. So let's say you had a woman who the AMH was pretty good, the follicle tracking looked good, and it seemed like she should be getting 6 to 10 follicles, and maybe there was only 2 or 3 eggs that ended up being retrieved. In that type of situation, are you looking at the medication protocol, or what are the things that you would be suspicious of?
I will tell you, first of all, if we break down a cycle, we need to break down the stimulation and the embryo transfer. And because many times there is a conflict behind fresh or frozen transfer, we need to ask ourselves also of why a fresh or a frozen, why we did what we have done. And also then we need to see if we have gone on a frozen transfer, about the medication before the transfer as well. So it's the medication during the stimulation, and it is the medication during the transfer, and if the decision to go on a fresh or a frozen cycle was correct. It's many different things that you need to analyze, and that's what we usually do when we have failed IVF appointments, which are amongst the most important appointments, because the persons that have failed the cycle psychologically and financially and everything, it's not good for them, it's very bad for them. So you need to explain, and you need to give explanations when you can give explanations. Now, as far as it regards the stimulation and the number of eggs that you can get, what I usually say is that you start with a specific number of follicles. Even the size of these follicles, if it is less than 5 millimeters or more than 5 millimeters, it is important. And the number of the follicles, it is very important as well. And the AMH is important. But you can never have in a stimulation more eggs than the follicles that you start with.
Yes.
So if someone starts with 20 follicles and we get 7 eggs only, something has not gone ideally in the stimulation process. What we try to achieve to say that the protocol was successful is two things. Is to get as many eggs given of the number of the follicles that you started, and also to get a very good maturity rate. When you get a very good maturity rate and you get a good number in comparison to the follicles that you start with, the protocol generally is successful. Because what happens after that, it depends on many factors. It depends on the lab, it depends on the sperm, it depends on other things after that.
Yes, that's a good way of separating things out for people, because obviously that first aspect is very much focused on how the woman is responding to the medication, and indeed the quality of her eggs and what may have been going on with her hormones, etc., in the lead up to that cycle, nutrients, everything relating to folliculogenesis. So on that side, if we put aside for a second the sperm and indeed the internal environment that would affect the embryo implantation, if we look at just that side with the eggs, so if you have that situation, as I've seen for people before, where let's say they had looked like they were going to have 10 or 11 eggs because of the follicle development, but in the end there was only 7 retrieved and only 5 were mature. So it was a big attrition rate. In that instance, you know, are you basing it off of the woman's age? Do you think that is having something to do with it, or are you looking to the protocol itself, as in the drugs that she's taking?
And I think of us if the age plays a role. Yes.
Yeah.
Or if it is the medication that you have used. That's the question, yeah?
Correct. Correct.
Okay.
Yes.
Right.
Yeah.
Age usually affects the quality of the eggs, usually affects what happens in the laboratory. But because age usually is related to the number of the eggs, as you are getting older, the number of the follicles that you have and your AMH is getting lower. So most of the times you are getting less eggs as well. But if you get less eggs than what you expect from the beginning, the first thing that you need to look is if everything has been done correctly with the doses and with the way that the doses change during the protocol.
Yes.
I see many people, some units, etc., that I mean, they don't check, for example, the blood tests. They don't do often ultrasounds during the stimulation. It is not only the initial dose. It is not only if you will start on a short agonist protocol or a variation of a short agonist protocol, or if you will start low or high. Definitely, there are ways and there are guidelines and there are ways to decide on these things, because the most important thing, it's the first days where you achieve the recruitment of the follicles. But even after that, if you don't know what is the LH, if you don't know what is the estradiol in every scanner, you cannot really decide if you will need to give a bit of external LH and choose the right medication so that you can increase the LH more. If you can omit the adagonist, for example, in a short adagonist protocol, because if you keep giving that, your LH will go much lower. And this affects a lot, for example, the maturity of the eggs.
Huge.
Because if you reach the stage of the trigger and you have an LH, which is quite often in polycystic ovaries, you have an LH that it is 0.2, you will get immature eggs. If you haven't checked, you will not know that you shouldn't give adagonist at that point.
Yes.
You should choose the right trigger, and even the distance between the trigger and the egg collection.
Yeah. Vitally important. Sorry.
It's important.
Yeah. Yeah. So the timing, as in the 36 to 38-hour window. Yeah. Exactly. I think we need to break down that a bit more for people, because what you just flew through is, I think, at the crux of what I see for so many people. And so let's break down, to your mind, from what you would see then, and that the problems with the level of monitoring. How frequently should someone be having their bloods checked and having the scans in order to catch those problems? Because I very often see people left, you know, they might have one scan and then the next one is before the trigger. and
Yeah, no.
they're not catching things in
I
between.
mean, definitely it depends on the protocol that you choose because,
Yeah.
I mean, there are variations, but most of the times, short agonist protocol monopolizes IVF nowadays with the variation of it. I mean, between the first scan and the second scan, I mean, at least at Pelargos IVF, we have after 4 days. So we start giving the injections, and on the fourth day, after 3 injections, we always check.
Check.
If you ask me, after that, if I could do blood tests and scan every day, I would do it. But you need to take into consideration other things. Okay, the cost, how easy is that to happen, the coordination for people that are coming from abroad. So it is not always very easy. But
Feasible,
definitely after the fourth day of a short agonist protocol, I mean, at least at Pelargos IVF, we do scan and blood tests usually every 2 days. Okay. I mean, if we see that we can do it every 3 days, or we have a weekend, or it is difficult, okay, you can play around. But during a stimulation, we know that the stimulation lasts between 9 to 12 days, and the normal number of scans should be between 4 or sometimes even 5. Okay, and in all these scans, we should be able to check as well the blood tests, because that's the way of controlling the medication, and that's the way of improving the maturity of the eggs. Yeah.
Yeah, and I think that's so key for people to grasp, especially because, you know, sometimes, to use the Irish expression, people say, like, better the devil you know. So often people will just stay endlessly with a particular clinic, and it's quite clear when speaking to them that, you know, this isn't working, and the telltale signs due to lack of proper monitoring, like, what do you mean? Things like early ovulation, you know, they're told they've so many eggs, and then they go in, oh, I'm so sorry, you ovulated over the weekend. They're gone. Well, how did that happen if I'm taking, you know, the orgalutran cetrotide? So it's quite interesting to hear you say that, and really important, I think, for people to absorb it and realize that it is not all on them, especially in the context of how many times, of course, you see women being told, well, it's your age, it's your eggs, it's you, it's your body, and the level of guilt that people feel and stress. So it's really refreshing to hear that, and the acknowledgement that the tracking is really important. Of course, paying heed to, as you said yourself, the balance between cost and logistics and everything for people as well, because they have to take the time, but that's really helpful. So the monitoring in that first stage, critical, obviously, in the lead up to. Now bring me back to the part about, because obviously different triggers for different situations and the maturity, etc. Let's talk about that, because that's when the Wi-Fi cut out, just when you were talking about the timing and the difference in hours for collection.
Okay, about the triggers, yes?
Yes, about the trigger, because obviously some people might have one trigger and not realize they might need to have the two.
Yeah. Listen, about the triggers, there is a very clear answer. To decide if someone will do a fresh. I mean, in order to decide, first of all, if someone we know from the beginning that will do PGTA, we know that she will freeze. Okay. Many times we prefer, in women with poor ovarian reserve, to freeze, to bank embryos and repeat the procedure. So in this case as well, we know that freezing will be the process. There are some women that they are coming, especially from long distance, and they don't have a reason of doing PGTA, and they want to finish everything in one go. Because, you know, nowadays we have reached the stage that sometimes we freeze even when we don't need to freeze. It has become like a fashion. So when everything is okay at the time of the trigger, first of all, you need to decide what the day of the trigger is. You need to know that this day I will need to trigger. And on that day, you need to check also the estrogen levels and the progesterone levels. And the progesterone levels are very important, because progesterone levels can go high quite often, even with low estrogen levels. And if you do a fresh transfer with high progesterone levels, it will not work. So on that day, you need, by taking all this information, to decide, first of all, if you will do a fresh transfer or if you will need to freeze to achieve better results. If we need to do a fresh transfer, always we need to have amongst the triggers Ovitrel. We need to have HEG, yeah, or Pregnil or medication that has HEG. Because if you trigger with Arvecap, if you trigger with Gonapeptyl, Decapeptyl, you know, I'm saying all the brands, it will not work, most probably. So fresh transfer, it means that it has Ovitrel. For women that are polycystic ovaries, you avoid using this medication because it can cause hyperstimulation. So in these women, you need to give agonist trigger. Okay. Now, it's very important as well, the dosing. Sometimes we give just one agonist trigger, and the right dose might be 2 or 3 agonists trigger. The way that we decide, it depends a lot on the LH levels. And that's why I'm saying that it's usually omitted. We check estrogen, we don't check LH. We know that when we have very low LH levels, it is better to give increased portions of agonist trigger in order to increase the maturity. So there is no answer, no clear answer on what is the right trigger, apart from the fact that when you do a fresh transfer, we know that amongst the triggers, we will need to use HEG. How much agonist? If it will be 1, 2, or 3, it depends again on the blood tests and the way that the protocol has gone. And double trigger is a very good option when you are not afraid about hyperstimulation. We very often use it in women that are especially poor ovarian responders or have bad quality embryos in the previous IVFs because it has some studies that shows that it can improve the quality. So the trigger is a very important, as you said, thing, and we need to decide personalized given of what is happening on the specific cycle. Okay.
So again, just to summarize that for people who maybe think, oh, it's just some little thing that you take to just make the eggs pop out. You know, it's about so much more than that. And that's why the monitoring before you're taking the triggers and also the timing, that window, I just wanted to emphasize as well, because I was speaking to someone at the fertility show who had been very stressed at what happened with her clinic because the window got pushed out, we suspect, too far. So it was at the 36 hours she was supposed to be there, and it wasn't until the 39th hour. So if you could just expand a bit about the timing and why that's important.
Well, 39 is long. 39, you put yourself into a big risk of losing the eggs, okay? Because there is a specific window through which ovulation happens. So it can vary, usually between 35 to 37. It can be a bit less than that. It can be a bit longer, but if you prolong it much longer than 37 hours, you are in a big risk of actually losing the eggs and not finding any eggs. I mean, especially in polycystic ovaries, and especially when through the protocol, through the process, your LH levels at the time of the trigger are very, very low. We usually prefer to go even higher than 37 hours. And this helps a lot with the maturity of the eggs. Because, you know, the main problem with polycystic ovaries is how many mature eggs you will get. You get usually a lot of eggs, but it's very difficult to balance all the follicles to bring them at the same stage at the same time. So you increase this benefit of getting mature eggs, because only mature eggs can get fertilized. Now, if the LH at the time of the trigger is like high, you know that you need to shorten a bit the distance. So even this distance between 35 and 37 hours, it depends again on what is happening. But definitely 39 is too long. Yeah,
exactly. Yeah. So thank you for expanding on that, so people understand the nuance and the importance of the little details, because when people are stressed and they're trying to find answers, it's really helpful to know that. And so let's go beyond that. So we've got past the trigger, we've got to the point of the egg collection. Now, something that I've also been asked before, and I'm sure you've seen, is where people are surprised that they had some empty follicles or follicles that, you know, weren't responding as they'd hoped. So in that situation, what would you be looking at for someone who's disappointed that they thought they were going to get more eggs from the follicles than they did?
Yeah, listen, again, you need to go back and to see if you have made a mistake, first of all, as a doctor. Okay. First of all, the first question is that the patient really took correctly the trigger. Okay.
Yeah.
And you can check it as well with blood tests to prove that or not. We know that mistakes happen, it's human. The important thing is to explain the importance of doing it at the right timing. Many times, sometimes actually, we had people that got confused, they did it at the wrong time, so the explanation was very easy of why we didn't get any eggs. Now, if everything is done correctly and under the instructions, then you need to go back and see how many follicles we had. Were the follicles smaller in size, bigger in size? What were the estrogen levels? Were the estrogen levels corresponding actually to the number of follicles that we had or not? Because the average thing is one egg corresponds usually to about 3 to 500, okay, to get an egg of estradiol. So you might have like 10, 12 follicles, and your estrogen levels will correspond to much less eggs. So maybe when you realize that, it gives you the thinking that in the next attempt, in the next cycle, the trigger was not done at the correct timing. Maybe the follicles needed to increase a bit more. You needed to give it a bit of more time to get the smaller follicles bigger so that you can get a bit of better estradiol levels and get more eggs. Now, the proper empty follicular syndrome is quite rare, actually. And it's I think that it needs a thorough investigation if it was actually a wrong timing of the trigger and the ovulation happened earlier because you've missed something. You had a very high LH and the ovulation happened before the trigger, or if it was proper empty ovarian follicle syndrome. And if it was proper, then there are few things that you can do. Growth factor has some studies behind it. You can choose and you can see if maybe you have missed the wrong medication. Maybe LH was very important to mature actually the eggs internally, the follicles, and the next time you should give more LH rather than go only with FSH medication. It's many different things, and it is a very big conversation actually to analyze it and to.
But that's the point, that it does warrant a conversation as opposed to bad luck, let's just try again.
Exactly.
Which is what happens. So that's brilliant, very helpful in tackling that about that stage with the egg. So let's go another step further. I'm just going through the stages and then we'll get to all the great questions people sent in. So we've got to the point of collecting the eggs. So now it's the critical stage and you've got a good number of eggs, they're all mature, everything's looking great. So we're at the point of fertilization. So this is obviously a clincher stage because that's what people are waiting for that phone call the next day of how many fertilized. And so what are the problems that you would typically see happening there? Because obviously at that stage, there's the egg and the sperm to consider.
Exactly. So that's why it is very important to check the sperm about everything, okay? And especially in women that had problems with fertilization in previous cycles. It's much more important, but at Pelargos IVF, we actually check the oxidation of the sperm as well and the DNA fragmentation in most of the sperma. And one very important thing is the way of fertilization, okay? I mean, obviously, if we have a missed male factor and we do IVF, the failed fertilization can be due to that. Most of the clinics do ICSI. So to have a failed fertilization with ICSI, it's a bit more rare. And then the first thing that we need to check very well is about the sperm. Does the sperm has DNA fragmentation? Does the sperm has oxidation? we have new sperm selection techniques now, like Zymot, like Max, that can help actually with the DNA fragmentation and can select the sperm that will put the best sperm inside. If the sperm is very, very low, ionization of the sperm, mobilizing it, trying to do things. Sometimes when the male factor is very severe, it's very difficult to achieve good fertilization. You know in advance that the fertilization will not be good.
Have you seen much success with AOA being used?
Sorry?
Have you seen much success with the artificial oocyte activation with AOA?
Sometimes yes. Sometimes yes. Sometimes yes. Depending on the history of having a failed fertilization before, and depending on what are exactly the parameters that are wrong with the sperm, it might help. And we had better fertilization in cases that had unexplained very poor fertilization before. But again, it's not like a miraculous treatment. When the sperm has parameters that are less than 100,000 and motility is close to zero and DNA fragmentation is very high, you expect that you will have a fertilization that will not be good. And the fertilization is not only, of course, because of the sperm, it can be because of the egg as well. And sometimes it is very difficult to determine if it is the egg or the sperm. So what you usually try to do is you rule out any possible factor and
because that's the best we can do. I mean, we're not quite at the stage, apart from the Aurora test, to be looking at the eggs in that way. So you're trying to just eliminate one of the variables. So that's at the sort of day 0 to day 1, just the fertilization point and the things to investigate if there's problems there. And this is, of course, a big one and hugely common. The fertilization happens, let's say there's 10 eggs, 9 of them fertilized, so that's good fertilization rate. But by day 3 to day 5 is when you're starting to see a big attrition rate. From your experience, do you tend to focus in on the sperm, just given the genetic material, the way it's behaving at that point with the blastocyst development, as opposed to the eggs?
Okay, we have a theory that when we have a poor conversion rate to day 3 to day 5, most of the times it is related to the sperm factor, because the sperm actually goes inside the embryo and helps with the division of it after the 3rd day. It is very important also to see what is happening between the day 1 to day 3, because when we have problems between day 1 and day 3 and the quality of the embryos is not good in day 3 and some embryos arrest, then most of the times it is the egg. Checking the sperm and determining what exactly are the problems so that you can use the sperm selection techniques, give antioxidants, give some multivitamins that help with the quality as well are, the common things that you do. And as far as it regards the quality of the eggs most of the times is associated with age. So when someone is older, you expect the quality to be poorer. So if we have a woman that is like 46, 47, the explanation is quite easy sometimes of what is the problem. But there are cases that sometimes the quality can be attributed to the protocol as well, to the trigger timing. Something has been done wrong on the time and the day that you triggered, and many times we have improvement in the quality of the eggs, better eggs, if you change few things in the protocol.
Yeah, which is so important for women to hear that and to know that it's not all them, that there are outside forces involved here too. So thank you for saying that. And so then they've got past, the day 3, day 5. Now let's talk about that key area of day 5 versus day 6 and even day 7 embryos, although I know a lot less common. But I saw a client with one recently because I was speaking to a couple yesterday that I was reviewing with, and they have a day 6 embryo to use as opposed to day 5. And I was just explaining to them perhaps the differences there potentially with quality, and then obviously the grading with the letters that I know confuses people, and the number to do with the stage of expansion of the blastocyst. So maybe just run through the differences there and what you'd ideally be looking for.
Yeah, a blastocyst is a blastocyst. So even if it is day 5 or day 6, it means that it has formed a cavity. So both of these are blastocysts. Sometimes an embryo delays to form this cavity. It's not ready yet by day 5, so you give it a bit of time to do it on day 6. If you have usually day 5 embryos are better than day 6 embryos. So if you compare a 4AA day 6 to a 4AA day 5, a 4AA day 5, it's better than a 4AA day 6. Now, the letters and the numbers, for people that do not know, the letters have to do with how the embryo looks in the microscope, and the numbers with the size of the embryos. You get an evaluation of all these things, and it's a matter of the embryologist, of the doctor, to explain to the patients what exactly it means and what exactly is the best embryo from all the embryos that they have. Okay, and what they will prefer to transfer first. Okay, all this is an evaluation process that is done by the embryologist, is done by how the embryos look in the microscope, follow some specific guidelines that are general, and nowadays we also have artificial intelligence. I mean, at collaborating laboratory, we use AI methods like Chloe Q, for example, that gives an algorithm actually about the chances of implantation of its embryo. And we are not based only on that, but we take all the things together. We take the prediction by the AI, we take how the embryos look in the microscope, and we choose through all these things what is the priority of the embryos, what to put first, what to put second, etc.
So these obviously in situations we're not doing PGTA, where they're not doing a biopsy to genetically test.
But even if you do PGTA, it's a different thing to get a euploid embryo that it is 4AA, and it is a different thing to have a euploid embryo that it is 4BB or 4BC, because we know that when we do PGTA, we take a biopsy from the outside part of the embryo. Sometimes it might not correspond to what is happening inside. And when the embryo does not look in the microscope, it has a bit of more chances not corresponding.
Yeah, I'm really interested to see the difference that AI will make on that front in the next, even in the next 2 to 5 years. I mean, with the speed at which it's moving.
I think we are heading there, even though I don't believe that we will stop taking into consideration also what the embryologist really sees.
They'll work together, but I agree. Just because for those cases where maybe for whatever reasons, cost or time, that they're not looking to do the genetic testing, and also because it's not infallible, it's a screening. So, you know, there's lots of scope there for, I think, improvement over the coming years, which would be great to help people. So that's brilliant. Thank you for giving me the context. I just wanted to really break down the trajectory of each stage and what's important at each phase. And the final phase, before I get to the questions next, I know there's a lot of questions, is, so you've got that embryo, it's day 5 or day 6. If we're talking about a failed cycle, and you were saying, well, it's relating to whether you have a healthy pregnancy, at the end of it all, we have to talk about the internal environment. So you're taking that embryo and you're putting it inside. So assuming that everything had been looking good up until that point, if you were happy with the protocol, happy with how the embryo was looking, I presume at that juncture, you would be asking questions about what might have been overlooked internally.
Of course, there is no 100% in IVF. Sometimes we might investigate and we might look about everything and we still don't find a reason. But the thing is that we need to investigate, okay? When we are failing and failing and failing, we need to exclude the reasons of why it hasn't worked. So yes, when you have especially euploid embryo that gives you chances of about 70%, or when you have in a woman that is 30 years old, a 4AA blastocyst that gives exactly the same chances, and you put it and it fails, then you need to go back and see what happened. First of all, was there any problem in the embryo transfer? Did you have any problems passing the catheter? Was it an easy embryo transfer or not? Did you check the progesterone levels before you do the embryo transfer? And then, I mean, you need to go to other things. Maybe a hysteroscopy. I mean, some clinics suggest hysteroscopy for everybody. Some clinics do it after a failed transfer. We usually do not do it for everybody obligatory. We recommend it, but we don't oblige people to do it for everybody before a straightforward embryo transfer that the ultrasound was absolutely clear without a relevant history. But when we have recurrent implantation failures, when we have recurrent miscarriages, then definitely you need to do a hysteroscopy because you can get information that you don't get by the scanner. And not only that, you need to investigate about chronic infections possibly, that you can only do it by taking a biopsy inside the lining of the womb. You need to go back and see where the levels of the progesterone, okay? You need possibly to go through the immunology part and check other things as well, compatibilities, natural killer cells. Do we need to add steroids or not? What protocol did we choose? Maybe someone has endometriosis or adenomyosis and we omitted to give downregulation medication. So next attempt should downregulate the ovaries because it helps with the implantation. So it's to break it down and to see what you have done wrong, to investigate, find the reason, and do the next embryo transfer under better circumstances.
Yes, and I love to hear you describing the A to Z there of what would be or what should be the basic, the minimum, like you said, with checking the progesterone, which I know is not standard in many other places. They don't often check that, right through to the more complex stuff, to immune, KER, HLA-DQ alpha, whatever it might be at the other end of the spectrum. So really important to have that detailed conversation if that's how somebody is feeling, that they were very let down, that they've had one or more embryos not working. Which is why I want to dive into the questions now, because now that you all have the context for this conversation, we want to get into your questions. The first one here that I'm just starting from the bottom for you, Harry. What protocols would you suggest for 2 previous cancelled cycles of IVF with high dose medication due to a poor response? Just very sorry for this woman. That's very tough.
Okay, I don't see the questions.
That question is at the bottom. So what protocol would you suggest for 2 previous cancelled cycles due to poor response when they were using high dose medication? And we can probably gather which direction you're going to go with that one. I think you've got the Wi-Fi glitch again. Did you hear that?
Difficult to answer. Yeah, this is knowing what exactly has been done in the previous protocol. I mean, first of all, was it a short agonist protocol? Yes, most probably yes. We have a cutoff limit at Pelargos if we have more than 5 follicles or less than 5 follicles. So when we have more than 5 follicles, we prefer to go high initially because you can get more eggs, and we have a clear evidence, especially in women that are more than 40 years old, that the more eggs you get, the more you increase the chances of one of them being chromosomically normal. If someone has only 2 or 3 follicles, though, even if you give a high dose of medication, you will not be able to get more than 2 or 3 eggs that you can get them with a low dose protocol. So in cases, so in cases like that, there is no reason, and you can go more smoothly. So if someone has a poor ovarian reserve, age plays a role as well that we don't know in this case, and started high and it didn't react, then yes, might be a point of going a bit more smoothly, using a protocol with letrozole and lower approach, using a protocol with Serpafar, with Clomid and lower approach. Try to see if in the luteal phase someone has more follicles and we can start the stimulation in the luteal phase. Many times in poor responders, we can start in the second phase of the cycle rather than with the beginning of the period. Maybe there are grounds of doing a double stimulation protocol. It depends. Okay.
Yeah, it totally depends. But I think particularly having had that happen twice, you know, once, but twice, I think you need to change things up for sure. So I hope you're able to figure that out. Next question here. This person writes, I don't feel that my IVF clinic are listening to my concerns about autoimmune issues and high inflammation. They are not adapting my protocol for these issues, and I'm being told, there is not enough evidence. What should I say to get them to listen before my next transfer? I don't want to waste my last embryo. So there's a lot at stake here for this woman.
Yeah. Okay. Okay, usually immunity, inflammation I don't really understand where is the inflammation and how is the inflammation proved.
Perhaps symptomatically, maybe it's what she's actually experiencing with her health that she has concerns about.
Okay.
Mm.
And I mean, usually these things do not affect unless we have a generalized condition, a medical condition,
Mhm.
the stimulation process. Usually they affect more the implantation process.
I think that's what she's referring to,
By
like the
any means, if
transfer.
we have, by any means, if we have a relevant history, definitely we need to check either with blood tests or with a biopsy.
Mm-hmm.
What we usually apply at Pelargos IVF is a biopsy. We prefer it because what is happening in the blood, it is not always relating to what is happening with the womb. So we prefer to take a biopsy. It's a specific test that tells you exactly what is happening at the time of the implantation. And then you get a protocol and you say if your immune system is overreacting or underreacting. And depending on the result, you might decide to give steroids, you might decide to give medication that suppress the immune system, or it might be the opposite thing. You might need a bit of more luteal support, a bit of more progesterone or HCG, and it helps.
Mm-hmm.
But you need to know what exactly is happening in order to give the treatment. Inflammation is a
Of
very
course.
general process, okay?
Totally,
Because
totally.
PCOS,
It is.
PCOS is inflammation, endometriosis is inflammation, a chronic
Mm-hmm.
endometritis is inflammation, and for
Mm-hmm.
each of them, you need to do specific things. Yeah.
Completely. But I think in the context of what she was saying about they're not listening, I would really encourage this woman to do not let your concerns be dismissed, because any time over the years a woman has said to me, I just feel that something's wrong, and then we discuss, like, they're always right. Like, they know their body best. So I think it's very important, if it's your last embryo, that, as you said, you do not let them waste it. So keep fighting, keep
Yeah,
pushing.
it needs investigation and needs clear answers.
Yeah.
What I usually say that okay, you need to trust your doctor as well sometimes. Okay, so when you choose a doctor, you need to trust, or when something inside you is telling you that things are not okay, okay, you can change clinic, but
Mm.
ask, make sure that you get some answers. Okay, if you don't get some answers, it's definitely wrong. Okay, but
Mm.
if you get some answers,
Then you can take action.
yeah.
Yeah, no, completely. That I would agree with that. The next person here writes, I had my first ever frozen embryo transfer on Monday, the 13th of April. So very recent. In preparation, I was prescribed corticosteroids and IVIG to treat elevated NK cells and low LAD. I obviously see this as my first real opportunity to conceive in 2 years, now that my immune dysfunction has been identified, as my thyroid is normal, microbiome, vitamins and minerals are excellent. I'm wondering, if this fails, would it be suspected that the embryo was aneuploid and there's nothing that could have been done? Well, that's the $1,000,000 question. Unless you
Yeah,
had
I
tissue
mean,
to analyze, yeah.
first of all, since that is the first transfer,
Mm,
um, it's also a question of why have we checked about immunology, because immunology is a very conflicting area. We
mm,
don't put every person that is doing an
no,
embryo transfer, the first embryo transfer ever, to do immunological testing. And especially, we don't put someone to spend all this money in immunological testing, and then we take an embryo that we don't know if it has normal chromosomes inside
and
to
put
put
it
in.
in, yeah.
It's very important to check. I believe a lot in
Mm,
immunology, in reproductive immunology, and we
yeah.
have worked a lot with it. But you need to know which are the people that need to check about it. Are people with recurrent miscarriages, recurrent implantation failures, previous failures? And
Mm-hmm.
then when you have a history, a relevant history like that, at least with us, we always advise to check the embryo first, because this is the most common reason of why it might not work.
I
And
suspect the issue is that in Ireland, since the introduction of the HSE funded treatment in the last, 2.5 years, unfortunately, not every case, in fact, most cases are refused PGTA. They're not allowed to do it unless they have a history of miscarriage with proven chromosomal abnormality with cytogenetic testing. So
It is,
makes
listen,
very,
Jessica, it
very,
is in Greece like that as well. Okay, we don't do PGTA to everybody because it's not allowed by the national authority. I mean, and to be honest with you, I mean, I'm a very big fan of PGTA. I know that in the US, for example, everybody can do PGTA, but when you have a woman of 34 with good ovarian reserve, with no problems,
oh,
you need to
that's
balance.
different. Yeah, of course.
Yeah, you need to
Yeah,
balance a bit.
she doesn't say her age here, but she does say 2 years trying, like
Yes,
first
yes.
opportunity to conceive in 2 years. That's a long time. So yeah, it's just to clarify that that's probably possibly why the embryo wasn't tested. So I suppose, yeah, it is possible that it could be an aneuploid embryo or a high-level mosaic if it doesn't work, but it's going to be
Exactly.
hard to tell, you know, unless it's tested. So the next one here, if you had one failed transfer, changed protocol, then the next one had a miscarriage at 7 weeks, should the protocol be changed for the next transfer? So I understand, but
Listen,
getting, yeah.
miscarriage is a thing that it means that the implantation happened. Okay, so it means that the protocol worked. Okay, it means not the stimulation process, but at least the embryo transfer process, the medication that someone has taken in order to do the embryo transfer and implantation. What happens after that can be related either to the body, either to clotting, either to immunology that we were saying before, or to the embryo. Okay,
Yeah.
so I wouldn't say that the process of implantation, the medication that someone has taken in order to achieve the implantation, was a problem. Maybe the most important and the most common reason is that the embryo didn't have the normal chromosomes inside. Okay, so again, depending on number of miscarriages, age, etc., one of the things to prevent miscarriages is the PGTA to check the embryo about the chromosomes. And of course, it would be good to investigate if someone wants about more rare conditions of miscarriages as well, like clotting, thrombophilias, and things like that.
Exactly, yeah, to look into all of those things. So yeah, I hope that it works out the next time, but definitely still do more investigations. And the next question, egg retrieval completed last year, but no eggs collected. How to improve this outcome for the next cycle? Going back to what we said earlier.
Yeah, it's a very general question. I don't know what happened in the protocol. I don't know if we are talking about a very poor ovarian reserve. I mean, definitely age is very important as well. There are many things missing from the history in order
Yeah.
to give a clear answer now.
Maybe if you're watching to add to the box a bit more detail. The next one here with a bit more detail, how to improve egg quality, thoughts on Omnitrope. So the human growth hormone. I've had 3 cycles, July short protocol, 3 blasts, 1 euploid, November long protocol, 1 blast, 1 euploid. Results today, short protocol, 2 blasts, 0 euploid. I have to say that's a pretty good outcome. I would have thought to get 2 euploids from 3 and from 1. What are your thoughts there on the use of adding in the human growth hormone? Do you think it's necessary?
Growth hormone, again, it's a medication that we work with. It's difficult to find it in Greece, but we have people that can find it from abroad, and we put it in our protocols. It's not a miraculous medication. It's not a medication that actually has a clear and consistent evidence behind it. But it has some studies that can help in some of the cases.
And also not automatically applicable if someone has a history of cancer or anything like that. It wouldn't be automatically safe to use it.
Of course. Yeah. We need to take a history, and we need to check that it would be okay to use it. It's not that it causes cancer, but again, we need to make a clear full history of the person, and there are people that have contraindications to use it. It's not for everybody. I mean, the result was not that bad as far as it regards the quality of the embryos, because I mean, out of 4 blastocysts, to have 2 of them euploid is a good result as well. So it is not mainly an issue of the quality of the eggs. We need to see why euploid embryos have failed. When a euploid embryo has failed, especially of good quality, good grading euploid embryo, most of the times is something else happening that is causing.
Oh, I don't think she's had any euploids fail yet, from what I read here. It's just simply that wants to improve the egg quality to get more euploids. I think
So
that was,
she's doing banking and she's collecting, she's trying to collect more embryos. Okay.
Sorry, Wi-Fi got you again.
In the protocol,
there you are.
Achieving it, okay, because usually Omnitrop works better when you take it from the previous cycle, because it helps sometimes with the recruitment of the follicle. So there are specific protocols about Omnitrop, and you can try it. It's an expensive medication, no consistent evidence, but we have used it sometimes with good results.
And that, what you said there, is key to the understanding of why it's so important to prepare in advance of the cycle, because the medication is obviously massively important, but it's you know, it's kind of pushing you over the finish line, but you're still running the marathon first. You know, there's still those months in advance. So exactly as you said, whether it be at the Omnitrope or any other factors that would affect the developing eggs.
Even if someone will take the pill, the combined pill to schedule a cycle, or estrogen priming, or progesterone withdrawal, it's important on what is happening in the stimulation.
Yeah, just as important. So next person writes here, getting 5 follicles on each cycle. For the last 4 cycles, I've been on gonal F, doing Ovitrel trigger and timed intercourse, had miscarriage last October. I'm wondering if the next step should be IVF. So that's
okay. So I suppose that we are doing ovarian stimulation with timed intercourse. Not sure why we have used gonal F on that. Most probably could be a bit of polycystic ovaries and not ovulating with like Clomid or pills or anything else. After 5 cycles of that, I would say that yes, it's a good idea to move to the next step. Yes, usually 5-6 cycles are important. I don't know if you want to try, depending on the age, a bit of IUI as well, but age is very important. Other things make the decision to IVF, but after 5 cycles could be the next step, yes.
Yeah, especially if you want to bank embryos, because it depends as well on your ideal family size if you want more than 1 child, because I appreciate the pregnancy in October, but yeah, still. So sorry to that woman. Next one here, reasons for unsuccessful fertilization after it previously worked. So this person obviously had a cycle that went well, but then the next one didn't happen with the fertilization.
Okay. We are talking here about fertilization, which means that none of the eggs fertilized. I don't know. Despite the fact that before fertilized, maybe something has changed with the sperm. Maybe it was just a bad getting of eggs on that time. We need to determine if it was more of a sperm factor or an egg factor, and make changes maybe to the sperm selection technique. In order to help with the fertilization.
Yeah, definitely. Sorry, I'm just trying to fly through the questions, because I know there were so many that came in, so I'll make sure we try and get to them all. Someone writes, first cycle, we've been given the age here, age 37, and the AMH of 52. So this is seeming like PCO tendency. 300 gonal F, 36 eggs, 34 mature, 22 fertilized, 5 blastocysts, severe OHSS, not surprising. Second cycle, added 3 grams of myoinositol and reduced to 225 gonal F, 37 mature eggs, 25 fertilized with ICSI, 9 conventional through IVF, all failed to fertilize, 6 blastocysts. Why the low blastulation rate? What would you change?
Okay. So what happened with this blastocyst? Have we transferred the blastocyst or not?
No transfer.
Okay.
It's just what's happening with the cycle. So obviously PCOS tendency, given the numbers.
Yeah, it's PCOS, definitely. Myoinositol, glucophage, and
Yeah.
medication like that can help. Omega-3, the preparation as well in order to prepare for your IVF cycle. The maturity rate out of 36 eggs to have 34 mature is impressive.
Yeah.
The fertilization is not
It's not bad in
too
the
bad,
context of
22 fertilized. Indeed, there is a poor conversion rate to day 5. Maybe you need to check a bit better the sperm about DNA fragmentation and oxidation, because many times the sperm plays a role on that. That's the first thing. And
so yeah, the information that's missing, like you said there, is what happened after. So we know the fertilization, right? And we know how many blastocysts, but what happened in between the day 0 to 3, day 3 to day 5, or day 6, because that's where the clues might be in this person's case.
Exactly. But for sure, we don't have a good conversion rate to day 5.
No.
Could be a bit of quality of eggs related, that polycystic
Because that's impacted, yeah.
ovaries.
Yeah. Oh, sorry, the Wi-Fi is catching you again.
Condition. So antioxidants.
That's
It's
okay.
an inflammation. It's an inflammation condition. So, antioxidants, myoinositol, glucophage, apart from reducing a bit the risk of hyperstimulation as well, they can help a bit with the quality. So a pre-treatment with all these supplements maybe can help with the eggs. The sperm needs to be checked more thoroughly, because most of the times when the conversion rate to day 5 is not good, it's sperm related. We check all these things and we try to improve. Actually, the only thing that didn't go well in the cycle, which is the conversion rate between day 1 to day 5.
Yeah, very much so. And I'd also add, maybe with this person's history, looking into the insulin resistance side of things, checking their glucose markers really well for the HOMA-IR score.
Yes.
To see what's going on, that they could hopefully help things next time round. And maybe PGTA, because that's a lot of embryos that you're ultimately going to end up with, that you want to know which are the good ones if you're looking to transfer. So the next one here, and then we'll probably wind up. I appreciate there may be some more questions, but I think we've got through most of them. I've had a number of cycles with 350 gonal F, good response. New clinic, most recent protocol was 600 gonal F, which shocked me on others, but still good response, but a failed transfer. I've asked what they would change if I go ahead. They said the same protocol. This is based on daily bloods, etc. Can I get your advice, please? Interesting. So
sometimes we increase the doses in more than 375 as well. It's a matter of cost, actually. We don't want to do it for lots of people, but sometimes we go higher as well. Most of the studies show that more than 300 doesn't play a very significant role, but when someone starts with very small follicles in the beginning of the cycle, these react better to very high doses. So sometimes we do that as well. Regarding things that you can do. Sorry, I missed the question. What is exactly the question? Because I'm trying to...
So the question was just being surprised that the new clinic had increased from 350 to 600.
Yeah, it can happen. It depends on the protocol. You can try an approach like that. I'm saying it's not common, but we use it sometimes. In situations like that someone is very poor ovarian responder, if the quality or it fails actually, and you cannot achieve good embryos with a high dose protocol, maybe there is a point of doing double stimulation protocols with lower approaches as well. So this is an option as well.
Yeah, definitely. Thank you so much for all the questions, everyone. I'm just looking at the time. Unfortunately, we can't get through them all. But in terms of everything we've covered this evening, because I think this has been a really helpful discussion and loads of key things that we touched on earlier on, as a closing, summary for everyone, what would you define as really the red flags to watch out for? So what are the things that annoy you, Harry, that you see happening to people on their treatment cycles that you think could be so easily avoided, or little changes that could happen that could make a difference to people's cycles, or the questions that they should ask their clinic?
Okay. I mean, we have a policy generally at Pelargos IVF, and as a doctor myself as well, I mean, it cannot be in IVF as well, one protocol fitting all. And yes, sometimes we don't know the answers and we don't know the explanations as well of why something is failing. But the more you investigate, the more you find things. When something fails, something needs to be changed. Um, okay, you will not be able always to guarantee or to achieve, of course, 100% pregnancies, but at least when you do an embryo transfer, you need to know, especially in women that have failed before, and especially in women that have, for example, only one healthy embryo, or their last embryo, or a normally euploid embryo after 3, 4, 5 attempts. This is a very precious embryo, and what I hate sometimes is to just repeat the same things, not investigate, and just spend an embryo like that, just putting it back without checking things. Okay. Tests, personalization, and getting most of the answers that you can in order to apply things that can help. That's what needs to be done.
Yeah, yeah, I love that. Thank you so much for giving that summary and context for people, and acknowledging your own frustrations as a doctor, you know, what you'd see and what people go through, because I think that's so important. Like you said, you can't guarantee anything, even with, I was just thinking as you were saying, oh, if something's not working, you've got to change it. But equally, just because something worked before, it doesn't guarantee it'll work again. You know, this is the tricky part with the whole process. So, but most importantly is to, you know, keep asking questions, keep pushing.
On the other hand, one last thing, that's the pessimistic side of me, that honesty. Okay, you cannot push someone to do egg donation, for example, when it's not psychologically ready for egg donation. So the decision is always on the person. But you know, the role of the fertility specialist is really to say the chances. Okay, honestly. I mean, I say to people that want to do IVF in their 47s and 48s that, listen, I haven't seen a live birth in the last 3 years. And I'm telling you, I'm advising you that most probably you are spending money and time in treatments like that. But I cannot push you. We can do the best that we can in order to achieve the one live birth that will be like very low in the statistics. But when someone has a consented decision, and when someone knows really the statistics, the money that will spend and what are the chances, then it's okay to go ahead, and you never know. And we had some very rare results, and this is the time that I'm saying, okay, it's worth, you know. But when
because
someone
it's people's
knows,
own choice. This is the point, exactly as you said. You're there to give the guidance and the information so they can make the informed decision, as opposed to being dictated to or misled. So I really appreciate the work that you do, and thank you for this lovely conversation. It's always a delight. And to everyone whose questions we couldn't get to, I'm so sorry. I really hope that the earlier conversation as well helped to give you context for those situations too. And as always, you know, you can contact Harry at Pelargos IVF or myself at the Fertility Detective if there's anything that we discussed this evening that you wanted to follow up on. But in the meantime, I hope that was helpful. Thank you so much, Harry. Thank you to my IVF Answers and the European Fertility Society. I look forward to seeing you at the next one.
You're welcome. It was always a pleasure to be together and do the sessions.
Absolutely. Thank you so much, Harry. Take care. Have a good evening.
Bye-bye.
Bye-bye.